Okay, let's kick off. Good morning. It's great to see so many people here. My name's Martin Marshall. I chair the board of the Nuffield Trust, and on behalf of our staff and our trustees, I'd like to welcome you to the 2026 Nuffield Summit. It's a real pleasure to look out and see some familiar faces. I say familiar, not old, and some new faces as well. Mike, you're familiar, not old, okay? It's always a great opportunity for the Trust, I think, to bring together leading thinkers in the health and care world, in the academic world, in the policy world, and just give you a bit of space to think differently, a space to sit back, to have conversations with interesting people, and hopefully to re-energize as well. I guess all of us are hearing different kind of conversations to conversations that might have happened in the past. Certainly in my nearly 40 years in the NHS, I've never heard quite such a strong commitment around the need for reform. I've got some colleagues, clinical colleagues, who might just say all we need is a bit more money, but most people recognise that we have an unsustainable health and care system and it requires transformation. So it seems to me that we're making a step in the right direction. We also hear policymakers and politicians in particular expressing a deep frustration about how difficult it is to get reform on the ground. They say the things that need to be done, and they're surprised that transformation seems to be so difficult, and it's not happening at sufficient pace or scale for either the public or for the political agenda. There's no doubt over the next couple of days we'll be talking about the kind of things that you talk about every day in your day jobs. We'll be talking about budgets, we'll be talking about waiting lists, we'll be talking about a whole series of things that you talk about every day. But I'm hoping that this will be an opportunity for you to step back and perhaps have different kinds of conversations about some of the bigger issues that perhaps you don't have time for generally. And the big theme this year, we have a theme each year for the summit, the big theme this year is trust. It's a theme that acts as a golden thread between all of the sessions of this summit. So we all know that trust underpins relationships, all relationships in our families, with our friends, in business, in government. And we all know that we are operating in a society that is less trusting than it used to be. A survey that was recently published suggested that in the mid-80s, nearly 50% of people had a significant trust in their government, that the government was doing the right thing for them. That figure has now dropped to closer to 10% and is dropping fairly rapidly. But we know that trust underpins effective relationships and effective working as well. We bemoan the loss of trust. Clinicians talk about having to work harder with their patients in order to gain trust to allow them to do what they need to do. Clinicians also talk about the bureaucratic burden of not being trusted by their managers to do the right thing. And managers certainly complain a lot about the lack of trust from the centre. They talk about more oversight, more data reporting, more box ticking, more regulation, more intervention. And this lack of trust has got implications that we all recognise. First of all, trust is an asset, a free asset, that allows us to work more effectively, allows us to be more cost-effective in the way that we work as well, and we're often missing out on that. And we know that lack of trust erodes professionalism, it can damage intrinsic motivation, it can lead to performative behaviours in which how you look, how you appear is more important than how you actually are. And perhaps most importantly, we know it can lead to gaming as well. Given the public expectations of system leaders and governmental bodies, I think it's hardly surprising that in the current environment, they're inclined to delve into checking rather than trusting. And I'm not sure we can blame government for that lack of trust if we are self-critical, if we're critical of our own behaviours. Too often we see parts of the health and care system that don't demonstrate trustworthy behaviours. Perhaps through omission, like, for example, not dealing with never events, and sometimes through commission, look at individual health professionals, and sometimes a tendency to be self-interested rather than interest in the public that we're serving. And R. O'Neill, the Cambridge philosopher who gave a stunning set of Reith lectures over 20 years ago on the balance between trusting and checking, said that trust and trustworthiness are two sides of the same coin, and that seems to be spot on. So our institutions, our organisations, our professionals need to be much more sensitive to how we can demonstrate that we're trustworthy in order to gain trust from both the public and from our organisations and from government. So the sessions today and tomorrow are going to explore this issue of trust. This morning, I'm really delighted to welcome back to the summit stage Chris Whitty. Again, it's great to see you again, Chris. Thank you for joining us. Chris is going to be talking about trust and information, the impact of misinformation and disinformation on what we do, and that's going to be followed by a panel discussion on finding common ground in discussions which are often increasingly polarised. Then Thea is going to be talking about trust in leadership, leadership in a low-trust environment, the risk of moral distress and moral injury when leaders are under pressure to make decisions which sometimes aren't aligned to their own core values. And that too will be followed by a panel discussion in which we will be exploring leadership in a range of different sectors. This afternoon, I'm really pleased to that we've invited Louise Casey to join us. Louise, amongst her many roles, is chair of the Independent Commission into Adult Social Care. Some of you might have heard her on the Today programme this morning, but this is her first opportunity in a public forum to talk about her early thoughts about the Independent Commission into Adult Social Care and what she might be focusing on. I don't think there's any doubt there needs to be a new settlement, and that new settlement is going to require trust. So an important discussion for us. The session after that is going to be on workforce and the morale of the workforce and the potential impact of the NHS workforce plan. And this evening we've got an informal session with David Haslam and Sally, who's going to be talking about what is the NHS for? What does it do? What can it do in a resource-limited environment? Tomorrow, I'm really looking forward to hearing Teun Tubas, who's a Dutch ethicist and activist who took the unusual step of moving into a care home for people with dementia and living there for a 2-year period. It's going to be fascinating hearing from him about how to better understand institutional models of care and the trust on which they're based. And then the final session tomorrow will examine the policy of moving care from hospital into homes, a policy that I think many people agree with in principle, but I don't think we've always thought through the implications of the housing crisis and the quality of housing standards on that particular policy. So we've got a really big, busy agenda for the next couple of days, but we've also got plenty of space for discussions between and amongst all of you and learning together. I'd like to thank our partners for supporting this summit. Optum, who are holding a lunchtime session today on AI governance, and the BMJ Group, who are holding a breakfast session tomorrow. They're our media partners on health misinformation. A little bit of housekeeping before I hand over. So first of all, most of the sessions are live streamed, so there is a bigger audience out there. You're the privileged invitees, but there's a bigger audience out there who will be enjoying and participating in the event. Please participate in social media if you want to. #NTSummit. We're primarily using Blue Sky and LinkedIn. If you want to contribute to the sessions, then please do so. It would be great to hear your comments, hear your questions. There is a roving mic. The mic will find you if you put up your hand. If you want to ask a question, please stand up, give your name and organisation, and then away you go. Phones, please turn them off. I know it's difficult, and try not even looking at them. It's incredibly liberating. I just come back from a trip to India, and I had my phone stolen on the plane on the way out. So I spent 3 weeks without a mobile phone, and I felt so good at the end of it. I really did. Even though I was using my wife's mobile phone, but still, it's a good experience. Evaluation, as ever, we're very interested in your views on the summit. Please give your feedback. There'll be forms on the table at the end of the session or online. There's no fire alarm to my knowledge, so if an alarm goes off, it's the real thing. So please follow staff instructions. And then finally, those of you who are summit experts will know that we usually have a formal supper in the chapel down the way. It's a gorgeous room, almost impossible to hear anybody talk, even people who are sitting next to you. So we're changing our plan this year. We're going to have a buffet supper next door, so much more of an opportunity to mingle, and I'm sure you'll enjoy that. So finally, I'm really grateful to all of you for giving up the time. You have busy lives, giving up the time to join us, to work together and learn from each other. I hope and think you'll find it a very stimulating experience and an enjoyable one for all of you. I'm now going to hand over to Becks Fisher. Thank you.
Morning, everyone. I'm Becks Fisher. I'm not even going to attempt to adjust these to a suitable height from me after Martin. 6 years ago, at the end of February 2020, our summit featured a talk titled The Direction of Health Trends Over the Next 20 Years, and given by Professor Chris Whitty, it generated significant interest, in part because it was given on the eve of a pandemic, which of course has shaped our public health trends since. On the heels of that, now we're delighted to welcome Chris back, now as Professor Sir Chris Whitty, to talk about mis and disinformation, the next public health crisis. I don't think I need to persuade you of the topic's relevance or the calibre of our speaker. After we hear from Chris, he and I are going to have a short conversation, and then we'll open the floor to as many questions as we can squeeze in time for, so please do get thinking of them. Chris, thank you so much.
It's great to be back. Very nice to see all of you. Thea, the reason I'm giving this talk is Thea asked me to do an expanded version of a short talk I gave at the London School of Hygiene and Tropical Medicine, basically because it's in the line with the theme of this conference. So I'm delighted to do that. I should be clear that I'm doing this as a jobbing practitioner, clinician and a public health person in government, not as an academic expert in this area. There are some fantastic academic experts like Heidi Larson, if you want to sort of delve into it in more theoretical detail. Now, I realise that conventionally you start to talk by saying how amazingly important the topic you're about to talk about is. I'm actually going to do the reverse and say we can often frighten ourselves by how much we worry about mis and disinformation and forget the fact that actually for the great majority of medicine at any point in time, it's actually a relatively unimportant part of what we have to deal with. But it is very important for specific things in specific areas. But really just to remind people that the stunning advances of medicine in the last 160 years, of which a very sort of shorthand version is life expectancy, the doubling in the last, over that period, throughout that time, mis and disinformation has been present. And it will be present for all time. It has been right back, certainly as far as the Middle Ages, you can find mis and disinformation. Second thing which we should remember is that the British public are pretty immune to large amounts of mis and disinformation. And if you look at, and the reason I make that point is, people who are pushing mis and disinformation spend a lot of their time trying to persuade everybody that half the population is on their side at least. And that is not true. And an example of that, for example, is vaccination, against which there has been a concerted campaign waged for decades, and if you go historically, actually over a century and a half. If you look at the uptake of vaccines by parents for their children, they're still over 90%, and quite a lot of the remainder are people who just find it difficult or inconvenient rather than because they got a philosophical objection. So the British public are actually extraordinarily sensible on almost all of these topics, arguably on all of these topics, and we need to remember that. But there undoubtedly is mis and disinformation, and it can in some cases be really problematic and prevent incredibly powerful tools of medicine, either preventative or curative, from being used. So we have to take it seriously, but I wanted to start off with that perspective. So why do people peddle mis and disinformation? Because it's often very puzzling. And broadly, these are my views about the reasons that people tend to do it. The first, and they're not mutually exclusive to be clear, the first and probably the most common is actually to do with financial gain. This may be whole industries. So, for example, the cigarette industry, which I'll come back to, made a profession of peddling mis and disinformation. That was just for their economic gain. That was the reason they did it. But many people who are doing it for economic gain persuade themselves they're not. So someone who says, you must not take vaccines, but by the way, the thing that works is my supplements are yours for only $23, is still actually gaining financially from the misinformation that they are pushing. Their reason for doing it is to do with their own business model. And I think the reason I think we should need to say that is because we should call it out when it happens. And that includes people pushing books, people trying to raise their professional status in the media, and so on. This is for financial gain. The second is they may have other incentives to discredit rivals, either individual or corporate, or indeed to have international impacts. During COVID, without going into details, I think everyone here is aware that quite a lot of disinformation came from what can loosely be termed state actors. They were doing it to cause chaos. It was done completely logically, followed a plan. It wasn't people who were mad. These were people who were systematically trying to undermine trust in governments or institutions they didn't particularly like. It was a deliberate policy. Then there's a group of people who really genuinely believe the mis and disinformation that they're putting forward. And this can be for lots of reasons: distrust of conventional science, dislike of all elites, which includes all of you, I'm afraid to say, certainly includes me, government, doctors, and lots of people are in that group. And in some cases, they got lost in a conspiracy theory. And once someone's in a conspiracy theory, getting out of it is extraordinarily difficult, even if they're very clever people. Then an area which I think, again, we should be honest about. Some of our colleagues push some of these ideas for reasons, as far as I can see, almost exclusively of vanity. Previously, they were a middle-ranking, perfectly decent clinician or academic. Once they start pushing these, they're invited onto the Today programme. They have a huge following on Twitter. Every time they tweet something out, they get 100,000 likes. It's very, very addictive. And I'm afraid some of the people you hear are simply vain. And again, I think we should be honest enough to call that out. And finally, there are many people where they have a very honest misunderstanding of science, or they actually feel their duty is to warn people of something which they believe themselves. And we shouldn't underestimate that in their own minds they're doing something actually for the public good rather than deliberately harmful. Now on the recipient side, why do people take notice of people who are peddling mis and disinformation? And the dominant one, by a very long way, is that they want the best for themselves, their families, their friends, and their society. And they're being presented with technically difficult and often alarming concepts and facts, and they look around using conventional search engines, and they just stumble across bits of information, and it's difficult for them to tell what is reliable and what is not. These are perfectly normally clever people, very public-spirited people. They're doing their best. And our job is to provide them with accurate information so that they can navigate this with a lot more certainty. So I think we should never blame anybody who, in a sense, is the victim of mis and disinformation. There are, in terms of those people, a very big difference between the vast majority who are actually asking legitimate questions and have legitimate concerns, and the very small number who are entering into a conspiracy theory. Why is that differentiation important? Firstly, because labelling someone a conspiracy theorist when they're not is extraordinarily both discourteous and ineffective. And secondly, because we need to identify the people who genuinely are in a conspiracy theory and realise that it is going to be almost impossible to stop them. All the academic literature, including in things like counterterrorism, says once someone is in a conspiracy theory, every single piece of information reinforces that conspiracy theory. So trying to change the mind of someone who's in a conspiracy theory is completely pointless activity. However, the great majority of people are not in a conspiracy theory. They've just heard some incorrect information. And for them, we've got to understand what their questions are, and we've got to answer them legitimately, fairly, honestly, and give them technically accurate information. So what are the questions that people want to ask? And in my view, and this is a slight variance from the academic literature, but this is certainly the way that I see it, I think most people have 4 questions and they ask them sequentially. And if the answer to any of them is no, they stop. They don't ask them. The first one is the disease serious enough and a big enough threat to me or my family that it is worth doing something about? If not, why should you go on to have a vaccine, take part in a lockdown or whatever? Secondly, does the vaccine or treatment actually work? If not, clearly why are you going to do it? Thirdly, are the side effects, I'm using side effects loosely here, reasonable relative to the risk? The general public are not stupid. They are well aware of the fact that every drug, vaccine and public health intervention has downsides. What they want to know is that the downsides are significantly smaller than they would have if they actually got the disease which we're trying to prevent. And then finally, and I think we often forget this, and I'm going to come to this last, how difficult is it to get? Because if someone's got a weak desire, for example, for their children to be vaccinated, quite a small practical barrier between where they are now and getting that vaccine is going to be enough that they simply won't do it. Not because they're against it, but just because we've made it difficult and they're just slightly convinced. So these are the 4 questions that we need to be able to answer, and as I say, answer honestly. And of course, the perception of risk will change over time. So what I've put here is people queuing for polio vaccination in the 1960s. At that point, everybody knew someone who had a family with a child with polio. Massive fear of polio. People would wait for hours in the rain to get their vaccination. Now, because you don't see polio, people will still get a polio vaccination, but they're not prepared to put up with those kinds of waits because they would see that as disproportionate, basically, to the risk that they currently have. Now, I only put this slide in because there are people in public health positions of authority around the world who are undermining this. So I'm going to just say really clearly, there are vaccines that are less effective, there are vaccines that have got side effects, but there are very many vaccines that work incredibly well. So this is answering the first question, is the disease dangerous? Second question, do vaccines work? The answer is they work remarkably in many areas. And this is the kind of data, in my view, that the general public like to see. They like to see something which actually gives them clear evidence that the thing is going to work. If there are any anti-vaxxers in the audience, the blue arrow is when the vaccine was introduced. And on the left, what I put is rotavirus, what happened every year as we went by, as we should say, basically just almost disappeared relative to where it was. And on the right, one of the most cheering graphs I saw last year, which the orange line is people in their late 20s, women who have had the HPV vaccination and what has happened to cervical cancer. And it is basically just going away. Now, that's the kind of information the general public want to hear, to be persuaded that these things are useful. There are people who say that HPV vaccination is not working. Pretty clearly, that is untrue. But for vaccination, disinformation, and I'm just going to use vaccines as the first example, have of course been around for a very long time. In fact, the earliest anti-vaxxers took to the stage almost at the same time as the first vaccine with Edward Jenner. And they've been there ever since. I've illustrated this with 2 of our greatest cartoonists, James Gilray, who was actually trying to persuade people not to have vaccines, and David Lowe, who was trying to persuade people to have vaccines. But in both cases, the point is the mis and disinformation in that era. Why did anti-vax start with Jenner? And the answer was there was a group of people who made their living out of a process called variolation. And they saw their industry collapsing in front of them if vaccination happened. So, for entirely rational financial reasons, they set about trying to discredit vaccination. It was simply money. Now, it then took on a life of its own, and at various points along the history since that time, smallpox, which you've got to remember was an incredibly dangerous disease that killed many millions, vaccination against it was highly effective, and by vaccination standards, fairly to very safe. But there were riots in parts of the country, for example, Leicester, when vaccination was brought in compulsorily. So the idea that anti-vax is a new phenomenon or more virulent now than it has been in the past is simply not correct. It's been there the whole time. The great example, however, the most systematic example of anti-vax, mis and disinformation is the two great industries that have made a complete professional job of this. The first of which was the industry that put lead into petrol, and then the second, who went even further, was the cigarette industry. And this is the playbook that people who are cynically going out to spread mis and disinformation, usually for commercial reasons, will follow. First of all, they will deny and fabricate evidence. And there's really clear evidence, again, in both of those cases, that's what happened. Then, at the point when the evidence becomes clear to any reasonable observer, they will spend most of their time trying to market doubt. And it's all about bringing in people to say, well, on the other side, the science is not settled. They will find some scientists who will want to be on the radio and will want to say, no, it's, my research shows it's more dangerous than people think, or it's less dangerous than people think. They paid scientists straight cash to do things. They chose people who are ideologically aligned. They managed to keep debate alive for decades after debate should have stopped. It was done very professionally, very systematically, and very effectively. It slowed things down. And of course, one of the other things they like doing, in fact, two of the other things they like doing, they like staying very close to big scientific institutions. They try and get themselves invited to WHO. We want to be part of the solution. They stay close to the media. They stay close to people like you. They will sidle up to you, not directly. They'll find a lobbyist, an intermediate lobbyist to do it, but you're absolute prime targets for mis and disinformation because you're seen to be opinion leaders in this room. The other thing they often use is the fact that many of my public health colleagues, and indeed my medical colleagues, enjoy arguing about the 5% of things where they disagree more than they enjoy trying to do something about the 95% where they do agree. And they find those areas and they home in on them. So, for example, for a long time, the public health community was incredibly split in this country on exactly what was the role of vapes. So every time the cigarette industry felt under pressure, they would throw in what about vapes questions, at which point the public health community would then argue amongst themselves for a satisfying 6 months, and we make no forward progress on cigarettes. And they do it repeatedly on lots of other areas. I'm just taking that as an example. So we need to be very careful that when we're having arguments that actually confuse the public, we're not actually being manipulated. Now, how about once things have started? I wanted to use an example not from the UK because it's, in a sense, at one remove, people can actually see how this works. The conspiracy, in northern Nigeria was the last place in Africa to have polio. And for political reasons, entirely cynical political reasons, some people in northern Nigeria, senior political people in northern Nigeria, wanted to discredit the government, and therefore they set about discrediting the polio elimination campaign. It was done for, in a sense, logical but bad reasons. Once the decision to try and discredit polio took root, however, almost everything that happened reinforced to the public that the conspiracy theorists were right, because the conspiracy theory had now taken root. So, for example, just to take two things, and if you were the family, you would understand this. You had a situation where people, if you went into villages where there were polio elimination campaign drives, they would say, very reasonably, our well has dried up, our school has no teacher, the clinic has no drugs, and yet the only thing the government cares about is giving us these vaccines for polio. This is clearly weird. And then they would see white people driving in twice, the only time they saw white people was driving in twice a year to help giving them polio drops out of bottles marked sterile. In that situation, is it not reasonable for someone then to say, actually, maybe these guys who say this is a conspiracy have got a point? And these so reasonable people if we're not very careful, can get to a situation where they believe a conspiracy theory because we've actually allowed a structure where, and it usually happens when we are, as the medical health profession, as the government, seem to be addressing problems which they see as irrelevant when they see much bigger problems alongside them. And they just think, why are these people concentrating on this incredibly small thing when there are these huge things which they're not addressing? So that is something which I think all of us have to take very seriously when we're trying to put forward public health policies. Now a word of warning, this is a health warning to my science colleagues. What do you do when you see conspiracy theories running riot on the radio, in the social media, in the press? And the warning is that the aim of some of the things that are said in social media by professional disinformation experts is to get you so angry that you respond. They want you to respond. And they want you to respond for at least 3 reasons. The first reason they want you to respond is you will then repeat their lies to a public who otherwise would not hear them. So you'll say, oh, it's outrageous that someone is saying that vaccines turn your teeth green. There is no evidence that the vaccines turn your teeth green. You've immediately told a whole bunch of people who had never heard that complete lie that that's something they should worry about. So the repetition is the first thing they want you to do. The second thing is they want to, remembering that the general public trust the medical profession, I'll come back to that a lot, they want to be given parity of esteem. So you being on one side of the argument and them being on the other basically raises their professional status relative to where they were previously. So they want you to debate with them. They want it to be 2 sides of the debate. They also know that they have a huge advantage over you, which is if you're tethered to being honest, evidence-based, not exaggerating, it's much harder to be interesting than if you basically can lie, and lie again. Making stuff up, being completely inconsistent, you can basically tell a fantastic story. So they will almost always be quite entertaining on the TV, radio, or anything else. And what they want you to do is then, to kind of match them, you tend to exaggerate your own case. And then they've got you. Because then they say, you claimed X, and they knock you down. And lots of scientists start off being very reasonable and get more and more irate as the interview goes by, and end up saying something which, in the light of hindsight, actually is not very evidence-based because they are so angry about it. And we need to be very careful of that. We should just be aware that better science and better scientists does not mean better media communicators. To be a good person in mis and disinformation, you're usually very good at communication, even if your science and morals are rubbish. Now, a bit about social media, overseas media and bots. This is the only thing that, in fact, is massively different about mis and disinformation now than what it was previously. And there are some very important issues on this. We all know that social media is an amplification cage, which directs people who've already got a worry further down the channel of other worries. So all the algorithms reinforce prejudices in either direction. But they're not doing it for any other reason than commercial reasons, but that's what they're doing. There are also large numbers of bots which are used to give the false impression of big numbers and big movements when that's actually not the case. And many groups get their social media from outside the UK. We need to just take account of those facts. They are realities. But we also need to remember that we can win the argument. And this is just an example. So pertussis rates in pregnant women were going down. There was a campaign based on the fact that there had been some pertussis cases, and pertussis vaccine rates went back up again. So I think we often convince ourselves that once we're losing the argument, we'll carry on losing the argument. That isn't actually true. It's possible to retrieve the situation. Finally, just a little bit about who do people trust. Government, as our chair very kindly pointed out, is not trusted by lots of people. The medical profession, the nursing profession, scientists are trusted by the general public, and that trust has actually not eroded very much. So government is often the wrong person, the wrong body to be trying to deal with mis and disinformation. All of the people in this room are in a much stronger position, in fact, to do so. Some people do trust government, and it's very important that people like me, in a sense, talk to those people, but we need to be aware of the fact that there are large parts of the population you cannot talk to, but others can. Almost everybody has someone who they trust. Therefore, if you can talk to the people who they trust and persuade them, they will do the job. So during COVID, for example, the people who the Somali community in the UK talked to and listened to were ethnic Somali doctors and nurses who kindly did it in their own time, talked to their communities, and in a sense, they provided the bridge. People like me constantly saying something on the TV were not going to cut it at all. They needed to go via much more trusted local environments. So we just need to find the people who people trust and then work with them. And very finally, it is important that we as practitioners, when we see things like vaccine rates falling, don't fall into the trap of saying, well, it's all mis and disinformation, these terrible, wicked people. Actually, the academic evidence is the majority of reductions in, for example, vaccination rates are because people find them difficult to get. They are practical things of delivery, not actually because people distrust the vaccines. And I think we need to look at ourselves and make sure we have done our job before we start blaming others for the fact that very often things are coming down. There's a very nice report, if people are interested in the academic background to this, which is done by the Royal Colleges of Paediatrics and Child Health, which is worth a read. So my summary is a lot of mis and disinformation is started deliberately by people with a vested interest, very often financial. We should feel completely unembarrassed about calling that out. Secondly, the general public are very sensible, repeatedly very sensible, and they want the best for their families. They will always have legitimate questions, and we must answer them fully and transparently. Scientific expertise and the authority of government help some people address their concerns, and we shouldn't underestimate this. So we shouldn't say don't use those channels, they are very useful. But for many communities, and particularly ones which often perfectly reasonably have quite a lot of distrust of government and authority, we need to go via people they do trust rather than just shouting louder from the channels of communication that we always use. And finally, good data and accurate descriptions of that data are really the key to winning the argument, in my view, rather than rhetoric, clever communications, etc. Data, I think, almost always wins. Thank you very much.
Chris, thank you so much. I wanted to pick up on the idea of trust, and as Martin wrote in his pre-summit blog yesterday, I think we often talk about trust when probably the conversation should be about trustworthiness. There were two aspects, I think, that I pulled out particularly from what you just said. One is about kind of the individuals and trust, and one is about institutions. Just thinking about individuals first, I possibly don't read the GMC's duties of a doctor as often as I could or should, but it's
a gripping read.
It strikes me that a lot of the things that you've spoken about reasons why clinicians might propagate mis and disinformation, fly very close to the sun with duties of a doctor or indeed any other clinician. Is there a role, do you think, or more of a role for medical regulators or professional bodies, whether they're all colleges or others, to step in and try and prevent that, or is that actually punitive and not particularly helpful?
There's a range of views on this. I'm at the rather cautious view of using regulation, except in the most egregious repeated cases. That's for two reasons. Firstly, quite a lot of people are doing it because they genuinely believe they're doing the right thing, and we should be careful not to penalise that. There is a range of acceptable opinion, and it's very important we don't use ways of trying to close down bits of opinion that we don't happen to like. So I think that's the first one. The second is that some of the people who are genuinely deliberate conspiracy peddlers actually have an exit strategy, which is a martyrdom strategy. Yeah. And in fact, being seen to try and bully them, in fact, plays straight into their hands. It's the truth they didn't want you to hear. They're trying to close me down, and so on. So I think we should be quite careful about that. Doesn't mean you should never do it, but I just think we need to be cautious.
And does that bleed in some ways into the kind of public trust in institutions? But you mentioned it in terms of public health sort of arguing amongst itself. Certainly in the days when I used to be on X, you would see somebody spread mis and disinformation. There'd be a kind of med Twitter pile-on of people. There are lots of reasons why public trust in institutions is changing and why public trust in the NHS is probably part of that. Does the institutional response need to therefore go beyond the individual to maintain trust, and if so, what would that look like?
Well, I think that I'd go back to something that Martin said about it. I mean, it is very important that everybody who is involved tries to maintain trustworthiness themselves, and institutions do their best as well. But you've just got to accept if you're losing trust, it's just a fact. But not everyone is losing trust. And I'd go back to that point. The nursing profession, the medical profession remain hugely trusted by the general population. By and large, science remains, in fact, science is probably more trusted by the general population based on polling data than it was 20 years ago. So the idea that there's a complete erosion is incorrect. Institutions have lost trust, but actually science and medicine themselves have not particularly. And I think we shouldn't fall into the trap of thinking we have.
Are you worried about a risk that when we lose trust in institutions, we reduce our ability to navigate health crises based on evidence rather than ideology?
Yes, I mean, every time an institution that is competent loses trust, it takes a long time to rebuild it, and it means it's going to be less effective in between whiles. But I think it is important also to remember that there are also multiple other routes by which you can get information. If, let's say, the government lost all trust in its public health messaging, and I hope it never will, but just to let's do that as a thought experiment, then the medical profession could easily fill that space itself. You could get the Royal Colleges doing it, you could get the academies doing it, you could get scientific bodies doing it. So there's usually alternative sources of authority people do trust, and if you have actually lost the battle on one side. And you can see that in some countries around the world, actually. Latin America, Bangladesh, for example, civil society has much greater influence in areas where the government is not seen as trustworthy, and it has therefore become incredibly technically competent. And I'm just using that as an example.
Very interesting. I'm putting you guys on standby. I'm going to come to the audience in just a moment. Chris, I just wanted to pick up one final thing. I think you mentioned the role of state actors in shaping trust in institutions to a certain degree. I don't want to ask you about how worried we should be about that here. My perception is that we should probably all be, to a certain extent, worried about that here. Are there things that our scientific institutions, our medical institutions, the Royal Colleges, the other non-government actors could or should be doing now to help maintain trust or even grow public trust in those institutions at the moment?
I'm afraid, boringly, it is all about putting out data and being very honest. There is no more to it, in my view, than that. What we don't want, for example, is people exaggerating the size of beneficial effect of something or understating side effects of drugs or whatever. Anything like that is rightly fatal to trust. I think provided people steadily, boringly, evidence-based stuff put in front of people, the communication can be more exciting, but the underlying science, the key thing is stick to the science, stick to what we know. Where you don't know, don't say you don't know. Where there's something that's inconvenient to your argument, be honest about it and upfront about it rather than hiding it. That's basically the way you keep trust, and I think that's the only way you can keep trust.
Brilliant. I'm going to come to the floor because I'm sure you all have lots of questions. We've got time for a few. Hands have gone up already. I didn't even need to ask. Where's the roving mic, just so I can see? Fantastic. Can we come to the front here in the black? Fantastic, thank you. If you could just stand up, just for our audio will be a bit easier. Thank you.
Hi, Rebecca Thomas, I'm health editor for The Independent. The debate around the puberty blocker trial has been one of the most polarising debates we've had recently, and I have two questions for you around that. What is your opinion on the way political and public figures have handled this debate? And secondly, are you in favour for the trial to be going ahead?
So I've deliberately stayed out of this debate because my view is far too many people have thrown far too many arguments into this where it's not their area of expertise. I think that the CAS review was actually a very sensible review myself. And what it said was, and I'm paraphrasing, a lot of the heat from this comes from the fact that there is relatively little or no really strong evidence in parts of this debate. And you don't create evidence by just stating it very loudly. You create evidence by collating what's known. That basically is my view on almost any area of science. I'm not going to comment on, I never comment on politicians, you'll be disappointed to know. And in terms of other public figures, I would encourage them to be as evidence-based as they can feel it in themselves to do, because I think that helps. I think it is really important people start with the fact that we're dealing with children often in distress, and a lot of the debate in the way it's conducted does not help those children. And I think that is the most important thing that we should start with. On the trial, I think my view is very straightforward, which is Hilary Cass's view that there isn't enough evidence in this area is clearly true. Trials is one of the ways you can do that. Can you do a trial in a way that is safe, appropriate, meets ethical standards? That's what's being debated by the appropriate bodies, including at the moment MHRA. That's the way the system should work. If at the end of it, there is a trial that all the ethical bodies, all the regulatory bodies and all the science bodies think is appropriate, then people like me will be supportive. If people feel that the ethics of this is not going to work, then people like me should rightly say, well, fine, that's the way the thing goes. So I take a completely neutral view on this. I think the system is designed, the UK system for clinical trials, in my view, is one of the best in the world, and I think we should allow it to do its job, rather than trying to second guess what the correct answer should be.
Brilliant, thank you. Again, this is where I regret not putting my glasses on. In the green at the side.
Hi, Laura Donnelly from the Daily Telegraph. You've been clear that you won't comment directly on politicians, so I just wanted to ask, do you think the advisors to Donald Trump think that their science and morals are rubbish?
I think I'm never going to comment on other people's morals because that's for them. On the science, I'm really clear on the positive side. I think that the science on vaccination, for example, which I think is probably what you're hinting at, there are other areas we could talk about, is in many areas rock solid. That doesn't mean that they don't have side effects, it doesn't mean that they always work, but do they have an effect on public health? I gave you 2 examples, I could have given many, many more, and much of those data are from US scientists done in US studies, and if you look at where the medical profession in the United States is, for example, their Academy of Pediatrics, they would be in exactly the same place as everyone here. So I don't think we should see this as a US versus anywhere else thing. This is a debate where almost everybody who understands the science is on one side of the argument on this, accepting all the pros and cons. There are people who are commentators and in the US and elsewhere who say things that are either misleading or actively untrue, but you know, where are the professionals in this? I think they're all in the same place, basically, and that is kind of where I park myself, because the evidence here is so strong. In contrast to the puberty debate we just talked about, here in vaccination, the evidence is really strong, and we should just simply restate it over and over again.
Chris, thank you. We're going to take 1, maybe 2 more. Becky, if we could come into the middle, the black and white shirt. Yep, just forward a little bit. Thank you.
Oh yeah, thank you. So my name's Ben Allen. I'm a GP and medical director at NHS Trust. I'm wondering, should we be doing more to democratise good information? So we want people to take responsibility for their health, yet in the NHS generally the only way to get that out is in one-to-one consultations. So you end up kind of, this proactivity creates a vacuum that the internet then fills. So I'm wondering, should NHS clinicians do more to connect at a population level, which is a lot like you actually modelled, Chris, in quite an unusual way that I think that could kind of serve that purpose. So what's the NHS's role in filling that vacuum? Should we be taking some responsibility for that?
I think absolutely, and I think that we are sometimes a bit flat-footed about the way we do it. I think the kinds of communication that I don't think either work or are right, actually, are ones that are really simplistic and strip out all the technical detail. My experience, both as a jobbing clinician and as a public health person, is people want to know why you've advised something, and they want to know what are the downsides up front so that they can make their decision, and both of those have to be laid out properly rather than just saying it's amazing, you should take it. That to me is not the right way to communicate public health. You've basically got to take people through an argument and then give them several layers of detail depending on what their personal preference is. And I think the expertise is in the health service, it's in the sciences, it's in the medical journals. There are people who are really good at this, and I think the more they can do it, the better, because different people are going to want different answers. But I think we should be laying out in front of the public and doing so in a way that is comprehensible.
Fantastic. And one final question. Yep, come right to the front. Sorry, Harvey.
Hello, James Owen from Health Service Journal. I just wanted to ask a quick one on NHS local leaders. You talked a lot about the trust of scientists and clinicians, but on managers, they're probably more lumped in with institutions. I just wanted to get your thoughts on how NHS local leaders should react to this agenda. And also, we've got the workforce plan coming up. AI is going to be, well, it's huge in this agenda, but in medicine more general and healthcare. And I just wanted to get your take on how that needs to be reflected in the upcoming workforce plan.
Thank you. I mean, those are two huge questions I will not do justice to. I'll give a very brief one to the first one, which is, I think my view about leadership in the health service, and indeed anywhere else, if I'm honest, is very similar to the medical thing, which is give honest information, give the downsides, don't pretend something's better than it is. That seems to me fairly fundamental, and I think we don't always follow that recipe. And when we don't, I think people start to lose trust, and possibly with justification. On the second, on AI, there are some areas of AI where it's very clear where its impact is going to be. For example, histopathology and diagnostic radiology, it's very clear that large amounts of that area of work are going to be taken over time. You can argue about the speed of it, but the fact of it is a virtual certainty. There are large numbers of areas where it is clearly not going to be able to do anything, and in my view, a large part of that is to do with the doctor-patient interaction. Most people ultimately want to, or doctor, nurse, doctor, other healthcare professional, they want to talk to another human being for much of what they're dealing with, and AI is not a substitute for that. And there are many physical things which AI is not a substitute for. In between those, there's a lot of stuff where it may have a role, and how big that role is, but it's very difficult to predict. And people who predict science more than 5 years into the future always make fools of themselves, because it never turns out the way they think it's going to. So I think the ones I've talked about, the radiology, histopathology, I can see a path within 5 years. Much of the rest of it, if I'm honest, may be really important, may be partially important, may turn out, in fact, not to work at all. So we'll just have to see.
Fantastic. Stay exactly where you are. We're going to segue seamlessly into a panel led by Leonora on whether polarisation is bad for our health, and you're going to find out where you are on your more in common political segments compared to everyone else. But first, please just join me in thanking Chris for opening our summit so brilliantly.